Okay, good morning, everybody. I'm sorry that this is a bit late, but I had to frantically rewrite some classes to try and fit the stuff into a single class. I'd made a mistake thinking we finished on Wednesday, and we actually finished yesterday. This is going to turn out to be just like a grab bag of remaining disease and conditions that I think you ought to know something about. So forgive us if we jump about a bit, but these are things of particular interest. The very first group that I want to talk about are diseases of the cardiovascular and lymphatic systems. Now, first of all, let's remember, I've told you before that very frequently bacteria will go into circulation in the body, in body fluids. Even such simple things as flossing your teeth or something like that can put bacteria into circulation. And this is almost never a problem because our immune system is designed to recognize the presence of those bacteria very, very quickly and respond efficiently to them and eliminate them from circulation. So this almost never causes a problem. But if the bacteria go into circulation and the bacterial population begins to increase, and especially if bacteria in growth some of them begin to die, release components, or the bacteria have virulence factors which allow them to produce exotoxins, which also go into circulation, then the body begins to react with symptoms of disease, of illness. And this is the condition of septicemia. Septicemia is the result of disease, is disease resulting from the circulation of bacteria in the body fluids or resident in the body tissues. And that is to be distinguished from the condition of sepsis. Sepsis and septicemia are not the same thing, although sepsis usually results from septicemia. And sepsis, in fact, is an immune response. It is an immune response which causes actual disease symptoms. The immune response is so powerful that, in particular, it causes dilation of blood vessels throughout the body, various other effects as well, but the principal one is the dilation of blood vessels throughout the body, which increases the blood vessel volume and drastically decreases blood pressure. And that blood pressure drop can be catastrophic and very, very fast. So this is often a critical medical emergency. It's also referred to as systemic inflammatory response syndrome, a syndrome because the immune response, this rampant immune response, actually causes many other problems as well. It causes most of the blood vessels to increase in volume, but in peripheral blood vessels actually end up contracting. And you can end up with organ failure because blood circulation to organs, for example, is cut off. It's a very complex situation. And I should tell you also, medically, a very, very difficult syndrome to deal with efficiently. So this condition of sepsis, it can have precursory kind of symptoms, but once it progresses to the severe sepsis and septic shock, then it is characterized by this catastrophic loss of blood pressure, and usually by the dysfunction of organ systems as well. And so this is these are the true symptoms of septic shock. The other term that we need to clarify is that of lymphangitis. And this is when bacteria and their components go into circulation in the lymphatics. And this is often one of the results here. This red line here is a line of inflammation, which tracks the passage of one of the lymph vessels under the skin here. What has happened is there's a site of infection down here somewhere. This is the arm, and then down here distal towards the hand, there's a site of infection with bacteria probably. And up here, proximal to the body, are the lymph nodes underneath the armpit. And so the lymph vessel is moving towards those lymph nodes. And bacteria, and very importantly, immune cells of the immune system are making their way through the lymph vessel towards the lymph node. And most of this inflammation here is actually caused by the passage of those living immune cells, because they are releasing hormones which are causing blood vessels to dilate. So as they diffuse out of the lymph vessel, they cause the local blood vessels to dilate. Now, this is a good illustration of how the shock systems are produced, because you can imagine these hormones are being released here locally in a localized system and causing these blood vessels to dilate, which is what causes the inflammation. But now just imagine that you have a generalized release of a large amount of these hormones from circulating cells of the immune system all through the body, causing all of the vessels in the body to dilate. You'll appreciate then that what you're looking at in a shock system is a generalized inflammatory system, which results in the catastrophic loss of blood pressure. Now, this red line, there are lots of myths about this, because it's quite a spectacular symptom of septicemia. The people will tell you, yes, you see the line proceeding, and if it reaches your heart, you die. But it's complete nonsense. This is a sign that you definitely have septicemia. You have living bacteria which are producing antigen, which is going into circulation in the lymphatics. And you certainly would like to have this dealt with as quickly as possible. And certainly it could proceed to a generalized septicemia, and it could conceivably end up in septic shock. But this is an early symptom, and it is quickly and easily dealt with. You're not going to die because you have a red line going up your arm. So let's just remind ourselves a little bit. Oh, sorry, I forgot to do something here. Just a little bit, excuse me for dithering around. There, that's better. So let's just remind ourselves about some of the causes of these profound immune responses. The immune system is responding to the presence of antigen, of substances which it can recognize. Now, some substances are very easily recognized and cause a very profound immune response. Others do not. They cause a lesser immune response. So some substances bacterial substances are profoundly immunogenic. They cause a very vigorous immune response. And some of the substances which cause the most vigorous responses are components of gram-negative outer membranes. Now, you need to go back and remind yourselves about the anatomy of the gram-positive and the gram-negative cells. They are different. The gram-negative cell has, outside of its peptidoglycan layer, cell wall, it has an outer membrane. It has another membrane, but that membrane is composed not of the normal kinds of phospholipids that make up the cell membrane. Instead, they're made up of one part of it is lipopolysaccharide. Here it is here. You can see there is the lipid part, and then attached to the lipid, there's a polysaccharide group. This whole group is profoundly immune response generative. It will excite a very, very strong immune response. And in fact, when it's released, it acts as a toxin, and we call it an endotoxin. And that is, the reason for that is, it's not normally released into solution from the bacteria. Bacteria do release toxins into solution, and those are the exotoxins. But this is a component of the cell itself, and it tends to be released when these cells die, which bacterial cells will do constantly when they're in circulation during septicemia. And it is these components which excite the strongest immune response and are most responsible for the production of septic shock. So any gram-negative bacterial septicemia is potentially extremely dangerous. And the commonest causes are things like E. coli, Klebsiella pseudomonas. These are all gram-negatives. And if they should go into circulation, they pose a grave risk to the person suffering from the septicemia. There's a problem in managing such a case, because if we immediately hammer the bacterial population with antibiotics, what we're going to do is we're going to actually wipe out most of the bacteria really quickly. They're going to burst and they're going to release all of this. And as a result, the management has to be very carefully scripted, so that, for example, you generally try to neutralize these lipopolysaccharides in solution with antibody treatments, or any other treatment that is available, and then also try to dampen the entire particular immune responses, which could result in a septic shock. As these are very difficult situations to deal with. So this is gram-negative sepsis, and it's by far the most dangerous of the septic shock systems. But you can also have very severe sepsis produced by gram-positives, and both Streptococci and Staphylococci are the commonest causes of these. And in the Streptococci and Staphylococci, it's not an endotoxin that causes most problems. It is that there are certain strains of Streptococcus and certain strains of Staphylococcus which produce very powerful exotoxins. This means that we can have a site of infection of the bacteria, and they can release toxins which go into general circulation and result in disease symptoms. And this is often referred to as a toxic shock syndrome. And it distinguishes from a generalized septicemia. Instead, there is a localized area of infection from which the toxin emanates. But there are also endotoxic effects as well. There are components of the cell wall and of the cytoplasm of gram-positives, which can also produce disease symptoms. These are very commonly associated with healthcare settings. For example, Enterococcus and Enterococcus faecium and Enterococcus faecalis, both gut-associated bacteria, are commonly associated with secondary infections in hospital patients, and especially infection of wounds and infection of the urinary tract. And together with Streptococcus and Staphylococcus, these are the major causes of gram-positive sepsis in hospital patients. Now, there's one particular sepsis, which used to be far more important than it is today, and this is puerperal sepsis or puerperal fever. And this is also called childbirth fever. And prior to the advent of, first of all, of hygiene around childbirth, but also prior to the age of antibiotics, puerperal sepsis was a major risk factor for women giving birth. And it is most commonly caused by Streptococcus Pyogenes, which is a common bacterium of the skin. It's a common bacterium of our microflora. So it's extremely easy to have a source of Streptococcus Pyogenes. And during birth, with poor hygiene, it is very easily introduced into the reproductive tract. And of course, after childbirth, there is certainly a lot of peripheral damage to the uterus, to the cervix, to the vagina. Minor, usually, but small wounds, etc., tearing of the mucous membranes, all of which serve as a portal for the infection by Streptococcus pyogenes. The puerperal sepsis usually proceeds from a cervical infection to a uterine infection, and then becomes disseminated through the body. And it results in peritonitis, or an infection of the abdominal cavity and of the peritoneum, which is extremely dangerous, an extremely dangerous situation. And women very frequently died extremely quickly after childbirth, within a week or so, of gram-positive septic shock. And this was such a huge problem throughout humankind's history that really childbirth presented one of the greatest risks to young women of all disease states. And it was only in the 18th century that it began to be recognized that good hygiene around childbirth could actually lower the rates of puerperal sepsis. Puerperal sepsis is still a major problem in developing countries, where women give birth at home and give birth under unsanitary conditions. Okay, so we're discussing diseases, bacterial diseases of circulatory system, etc. So I should mention that we can actually have bacterial infections of the heart itself, and this shouldn't surprise us, because you'll realize that if we have bacteria that are in circulation, inevitably they're going to very quickly start passing through the heart, through the chambers of the heart. The chambers of the heart are anatomically extremely complex, and they present to bacteria in circulation a multitude of surfaces on which they can settle and begin to grow. And in general, the structure of the interior of the blood vessels and of the heart itself, they are in general inhospitable to settling. You can think of them as being very slippery. But bacteria definitely are able to establish a foothold on these surfaces. And once they do, if they begin growing and manage to evade immune response to them, they will begin to excite immune reactions from the tissues themselves. They begin to excite inflammatory responses in the heart tissue itself, which can be extremely dangerous. Endocarditis is any infection of the lining of the interior of the heart. That's the endocardium, is the lining, interior lining of the heart. And this often proceeds from an almost chronic infection. Subacute bacterial endocarditis is most commonly associated with the valves of the heart, which provide a particular area for settlement, because as blood passes through the valves, it tends to eddy around the valves. You have areas where the fluid dynamics encourage settlement of bacteria on the valves. These are usually streptococci of one sort or another, but in particular from that group I've told you about before, the alpha hemolytic streptococci, gram-positive alpha hemolytic streptococci, or GAS, G-A-S. So this often is from just a simple throat infection, tonsil infection, bacteria go into circulation as bacteremia, and then can settle into the heart valves. It used to be thought in the old days that this was the cause of rheumatic fever. But as we'll hear in a minute, actually rheumatic fever is from another cause. It can have an associated bacterial endocarditis, but it's from another cause. Acute bacterial endocarditis is widespread colonization of the heart valves. And this again is a medically critical situation, because this so severely impairs the function of the heart valve that it can actually be fatal. And even if it's not, it can cause such severe damage to the heart valves that the heart is impaired even after the infection is cleared. And both of these situations predispose the heart valves to autoimmune attack by the immune system. So just a reminder that rheumatic fever is a complication of a strep throat, Streptococcus Pyogenes infection of the throat, or the tonsils, which produces an immune response to a specific type of protein which surrounds the streptococcal cells. Around the streptococcal cells, there is a capsule, and that capsule is partly composed of proteins called the M proteins. Unfortunately, M proteins closely resemble some human tissues, and especially those of the heart associated with the heart valves. And it seems that an immune response to the M proteins can trip over into an autoimmune response against tissues of the heart itself and produce damage of the heart. And that is true rheumatic fever. It may be predisposed by actual settlement of the heart valves by bacteria, but not necessarily. It may simply be a generalized autoimmune response to bacteria which are actually sitting in the throat. Okay, so here is our next glorious circulatory disease is that of plague, which I thought we should have here, at least hear something about, because it's in human history, has been such an important disease. It is classified as a disease of the circulatory and lymphatic systems because it actually many of the effects are concentrated on the lymphatics and on the lymph nodes. In fact, this is one of the principal symptoms of the bacterial infection, which result in plague. The organism that causes plague is Tinea Pestis, and it is a gram-negative rod. And it can be transmitted in human beings by two means. First of all, it can be transmitted by a vector, and this is principally a flea. The most important one of all is the rat flea. You don't need to, it's Xenocilla, but you don't need to remember the name. There are other fleas which can also transmit it, but this is the most important one. This, both the disease itself and these fleas are endemic to rodent populations. The rodent populations just tolerate the disease. It doesn't particularly seem to affect them, and it remains resident in these wild rodent populations, widespread all over the world. But periodically, we get outbreaks of the plague which enter the human population. And in these days, that is not of any particular importance because a plague is very quickly recognized, it has very distinct symptoms, and it's relatively easily treated with antibiotics. But in ancient times, it was an extremely dangerous disease, which caused mass mortalities. In fact, the last great plague in Europe killed more than a third, more than 1 in 3 people in the whole European population. The reason for that is that there is another way in which it can become transmitted. It is not only transmitted by the rat flea, but the infection itself can spread to the lungs, and it can produce a condition called pneumonic plague. It infects the lungs, people begin to cough, it causes a massive inflammation of the lungs and a hemorrhage in the lungs. People cough up spray of blood droplets containing the bacterium, and it can actually be spread directly from person to person, not necessarily through the flea vector. So it enters the human population through the rat flea, and then it can be spread from person to person once the epidemic gets going. So the entry of the bacterium into the human body is actually through the lymphatics. And the bacteria migrate to the lymph nodes. Now, here you can see these tremendous swellings here. These are lymph nodes which have been infected with Yersinia, produce these intensely painful, hard swellings of the lymph nodes, which are called buboes, B-U-B-O-E-S, buboes. And that is where the other name for plague comes from, which is bubonic plague. And bubonic plague, now remembering that this is a gram-negative rod. So along with the fact that this is doing really bad things to the lymphatic system, to the circulatory system, this is also releasing and producing all of the effects that we would expect from a gram-negative. It can produce a gram-negative sepsis. And the whole combination, in actual fact, untreated plague has a very, very high mortality rate, which is why it was so dreaded in ancient times. Once the plague entered the population and began to spread, could spread very, very rapidly. And of course, there was very little that anybody could do about it in ancient times. So the mortality rate is quite extraordinary, especially if once people acquire the pneumonic plague. It's up to 75% mortality rate. And as I say, coupled with that, there's an associated septicemia. And in addition, as part of that response to the gram-negative components of the bacteria, we get a strange effect in the peripheral blood vessels. First of all, the peripheral blood vessels started to actually constrict, and they release, and blood leaks out of them underneath the skin, and it causes this blackening. This is not gangrene. This is basically iron from the hemoglobin being deposited under the skin in the peripheral areas of the body, and it produces this blackening. And this is the source of the other name for bubonic plague, which is Black Death. And this is where the black part comes in. Once people develop these kind of symptoms, it was certain that they were going to die. And you know the old thing, ringa ringa rosies, a pocket full of posies, husha, husha, we all fall down, or in America, a tissue, we all fall down. That refers to the symptoms of plague. It's a children's nursery rhyme which refers to the symptoms of plague. Ringa ringa rosies referred to the fact that at the site of the flea bites, people would develop a lymphangitis, an inflammation which gradually would start to move towards the lymph nodes. Ringa ringa rosies, a pocket full of posies. People believed that if they carried specific herbs and flowers with them, they could ward off the illness. Ringa ringa rosies, pocket full of posies. Hasha, tissue, a tissue. That's the symptoms of the pneumonic stage of the plague. We all fall down. that's self-explanatory. Once you began sneezing and coughing up blood in the plague, you were done. So the origins of the nursery rhyme are a little bit grim. So as I say, this Yersinia pestis is endemic in rodent populations, and it's endemic here in the United States. And we periodically, every year, there are minor outbreaks of plague, but they are of no great import because it is really very easily dealt with. And especially the symptoms of plague, especially this lymphadenopathy that people produce, very quickly brings them to hospital. It's very easily identified and relatively easily dealt with. And it's almost never proceeds to pneumonic plague, which is the really dangerous way in which plague is spread as a contagious illness. So here is another one. This one you will have heard of. And this is Lyme disease. Again, a disease it's really a septicemic disease because it involves circulation of living bacteria that grow in the blood. But these bacteria are spirochetes. Here you see them here. These tightly wound spirals, bacteria. And remember our other spirochetes, things like the treponema, which cause syphilis. This is another spirochete, but this one is called Borrelia burgdorferi. And Borrelia burgdorferi is a name you should remember. It's the most common tick-borne disease in the United States. And it's acquired in human beings. It is acquired from ticks. And you'll commonly hear that these are deer ticks. And they do certainly, the adult deer, the adult ticks feed on deer. That is true. But we don't acquire the disease from the adult ticks. We actually acquire the disease from larval, not larval, but nymphal, juvenile forms of the tick, which are feeding on mice. And mice, it's the mice populations which provide the ticks that bite us, not the deer. So the deer, in fact, are not infected by Borrelia. The reservoir of Borrelia is in the mice itself, and that's where the larvae acquire them. So here's the distribution of Lyme disease in the United States. It's predominantly a northeastern disease. And in many people, Lyme disease is a self-limiting disease. I'll just show you quickly. This is one of the first symptoms. Again, this is really an inflammatory response to the migration of these spirochetes. And it produces, here's the site of the bite. Here they're migrating out away from the site of the bite. And it causes what's called a bullseye rash, which is very typical of Borrelia. Now, in many people, this is a self-limiting disease. Other people, they become more ill and require treatment and recover after treatment. But unfortunately, in some people, even after recovery, they maintain disease effects. There are sequelae to the disease. And these include things like neurological effects, brain fogginess, that people complain about brain fogginess, this memory loss, this sort of thing, but also arthritic disease and very generalized kind of organ disease, including kidney disease and things like this. And it's not exactly clear why this is the case, but it may be at least a component is an autoimmune response by the body's own immune system, which is maintained after the infection is actually cleared. This is Lyme disease. Here, you don't need to remember the entire life cycle. All that I want you to realize here is, here are the adult ticks. The adult ticks feed on deer. Deer are unaffected by the whole thing. But once she's well fed, the female tick lays eggs, a gazillion eggs, which hatch out into very small larvae. And the larvae, not larvae, but they're called nymphs actually, because they look rather like the adults. They're just like small adults. They are resident in rat and rodent populations here. And it is the rats and the rodents which maintain the Borrelia stocks, if you like. They are the reservoir for the spirochete. And these nymphs become infected and then go on to, if we are bitten or by them, and various other animals as well, can acquire the disease, dogs amongst them. But we have to be bitten by one of the nymphs here. We are not bitten by the adults. Okay, I think that's all I need to tell you there. So I just want to mention this one here. This is typhus, and I specifically want to mention this first of all because it does cause a very important disease in the worldwide, but especially in the United States. But I wanted to mention it because this is a very specialized kind of bacterium. This is a Rickettsia. It's this disease, typhus, which must be distinguished from typhoid fever, which was Salmonella, remember? This is typhus, and typhus is a bloodborne disease, and it is caused by this very strange bacterium called a Rickettsia. Rickettsias are very, very small and somewhat reduced bacteria, which are intracellular. They're obligate intracellular pathogens. And they infect the cells primarily of the vascular system in human beings. And as a result, just what you'd expect, all of their effects are on the blood circulatory system. And they can cause widespread and extensive damage, especially of peripheral blood vessels, with consequent, sometimes massive organ damage. Again, this is a disease which varies in severity, but it has the potential to be extremely severe or even fatal. And this is the commonest kind of typhus disease, rickettsial disease, is Rocky Mountain spotted fever. There are various others, but Rocky Mountain spotted fever is the most serious one, and one that we see in the United States. So it's caused by this organism, Rickettsia parozechii, but typhus is transmitted by a vector. And the vector for this particular one, for typhus itself, is Pediculus humanus, that is the body louse. So what happens is, I'm sorry, I just made a stupid mistake. And that is I got this confused with Rocky Mountain spotted fever. Forget what I said about Rocky Mountain spotted fever. You can tell that I had to put this together hurriedly. Let me just step back. Okay, we're specifically talking about typhus caused by Rickettsia. And this is transmitted by a vector. The vector is the human body louse. Forget what I said about Rocky Mountain spotted fever. So this works in a particularly nasty sort of way. The louse themselves are infected with the Rickettsia, and they feed on humans and they desiccate. But at the same time, they also cause intense itching. So what people do is they scratch like this, and they cause a wound into which they rub the feces. And that is what causes the actual infection. It is not that the louse is injecting Rickettsia into them. And this causes a prolonged fever and a rash of spots. And in the right conditions, for example, if somebody is very malnourished, something like that, it is frequently fatal. So, for example, in the concentration camps during the Second World War, in concentration camps, prisoner of war camps, places like that where people are deprived of food, typhus is extremely common because the lice are extremely common. And typhus tends to be a disease which is associated with deprivation, with situations of refugee situations and this sort of thing. And it can have an extremely high mortality rate in those populations. In a normal population, it is easily treated with tetracycline and chloramphenicol, and actually is really quite uncommon amongst populations which are well fed and which have minimal hygiene, etc. Okay, I'm sorry for my brain fart that led me off into something else, but please get this straight in your mind. And so here is what I got confused with. Here is another rickettsial disease, and this is Rocky Mountain spotted fever. And this is also called typhus, but it is tick-borne typhus. And tick-borne typhus is caused by this Rickettsia, Rickettsia, and it is a potentially extremely serious disease and actually has a relatively high mortality rate, which is about 20%. This in modern times for infectious disease, this is very, very high. And so this is a serious illness, but it really operates in much the same way as these rickettsias that cause typhus, in that it infects the blood vessels, but it causes, its major effects are also on organs. It causes organ failure, but especially it can infect the brain and result in neurological damage as well. So this is spread by ticks, not by lice, as typhus was. It definitely can be treated. Its name is a complete misnomer. It's called Rocky Mountain spotted fever, but for goodness sake, here's the incident. You can see the incidents here reported by county. So this is very much an Eastern American disease. Rocky Mountains are over here somewhere, and there are very few cases. I don't know how it got the name Rocky Mountain spotted fever. It's still widely reported. It's still especially is noted amongst people hiking and those people, wilderness backpackers. These sorts of folks are especially liable. And if you do that, it's very, very important that you conduct regular tick checks, that you wear proper clothing to avoid being bitten by ticks, and that you do regular tick checks. And you'll realize, of course, looking at the distribution here, you'll realize also that there's an overlap here with Lyme disease. These are two tick-borne disease, very, very different tick-borne diseases, both of the blood circulatory system. And that's this is one of the characteristics of Rocky Mountain spotted fever. It's where the spotted fever part comes from. You can see here. And it is also characterized by a very, very high temperature in the acute phase of the disease. Okay, so that's the diseases of the blood circulatory system, and we're going to move on. Oh, don't say. Let me just see. I hope that this works. Let me just, sorry to dither around, but I'm trying. Okay, I hope this is working. Okay, so I'm just going to very briefly talk a little bit about diseases of the skin. And and a brief reference to diseases of the eye. So you'll remember that I told you that one of the common members of our skin flora, of our skin microflora, are the Staphylococci and the Streptococci. And while they remain on intact skin, they are absolutely no problem. In fact, our skin is designed, the functioning of our skin is designed to maintain a certain level of bacterial populations, but to ensure that the bacterial populations don't become too high, and especially that they do not breach the barrier between the outside and the inside. But one of the commonest sources of infection of the skin and of producing diseases of the skin are the Staphylococci. And again, to remind you, here they are here, Staphylococci, they're cocci in bunches. And they're very, very easy to grow. They easy to grow on culture. And they have certain characteristics which allow us to categorize different strains. And there are many, many different species and strains of these bacteria. The commonest Staphylococci can, in fact, cause disease once they break through the skin barrier, if they enter a wound or something like this. And those that actually cause disease very commonly produce this exoenzyme, which is called coagulase, which affects the coagulation of blood and is one of the virulence factors for the pathogenic Staphylococci. However, many times an infection will be caused even by Staphylococci, which are coagulase negative. It is not necessarily a requirement that they have coagulase in order to be pathogenic. It's more circumstantial. So here is one. This is Staphylococcus epidermidis, which is by far the commonest of the Staphylococci on our skin. And unfortunately, Staphylococcus epidermidis is a commonly associated, healthcare-associated pathogen. And this is one of the common causes of wound infection in healthcare settings. Surgical wounds become infected with it. And it's not surprising because it's very easy to move Staphylococcus epidermidis from skin, either from the patient's skin or from a healthcare worker's skin into a wound. It's one of the reasons why scrupulous hygiene has to be observed around an open wound. Staphylococcus epidermidis can also produce biofilm, however. I told you here that it grew very easily, for example, in culture. Well, it'll grow very easily in other situations as well. And here is one of them. This is a catheter. And this is a catheter which has been colonized by Staphylococcus epidermidis. This is early stages of the infection of the catheter. And you can see it's growing quite happily on the surfaces. Bacteria love surfaces. I've told you that before. Here they have adhered. This is in a catheter. They're presumably surrounded by urine or whatever, and are extracting nutrients from and growing quite happily. And they begin to set up a biofilm very rapidly. They release substances as capsular components, which coalesce together to form this dense film. Very, very difficult to deal with in terms of trying to keep catheters clean, and especially to reuse catheters. And this is a thick layer here of the Staphylococcus. Then this biofilm here, and embedded in this biofilm, invisible to this photograph, is a thick layer of bacteria underneath. Not only are these producing substances which are potentially harmful to the patient, but they are a rich source of infection. So they are a rich source of infection to the urethra and then to the bladder and potentially to the kidneys as well. So the other component of our skin microflora is Staphylococcus aureus, and not as common as Staphylococcus epidermidis, but we also very frequently carry Staphylococcus aureus in nasal passages as part of the nasal flora. And the Staphylococcus aureus is coagulase positive. Epidermidis is coagulase negative. And it depends on the strain of Staphylococcus aureus. There are many different strains, and some of them potentially more pathogenic than others. But they may produce exotoxins. You heard about one exotoxin the Staphylococcus aureus produces that causes that violent food poisoning. That is one of the exotoxins. And Staphylococcus aureus can, if it goes into circulation in septicemia, can also cause sepsis. So a wound infection with Staphylococcus aureus is potentially extremely serious and needs to be carefully managed. However, these skin infections with staph are surprisingly common, and we've probably all of us had these infections. And skin infections with Staph aureus tend to be self-limiting, as I'll describe in a minute. They have various very skillful ways of avoiding immune responses, amongst them being that they produce a capsule which evades the immune response. In addition, they are actually able to actively kill macrophages, which is the macrophages are the major source of inflammation for the rest of the immune system. And if the Staph aureus is killing those, then you are disabling one of the first arms of the immune system. Up until recently, Staph aureus infections were relatively easily dealt with, especially by penicillins and other antibiotics in that penicillin family. However, Staph aureus populations, especially in healthcare settings, have developed multiple resistances to antibiotics. In the end, one of the antibiotics of last resort was one derived from penicillins called methicillin. And methicillin is an extremely powerful antibiotic. And it was hoped that methicillin would be the last antibiotic that would be needed, that Staph aureus could not possibly withstand it. But in fact, methicillin-resistant Staph aureus, MRSA strains, are now actually relatively common, especially in healthcare settings. And Staph aureus is a major cause of infections of surgical wounds, and so is an extremely dangerous component of the Staph aureus flora. Have a read, just read this section, please, in your textbook, pages 652 to 653. So Staph aureus frequently sets up infections of the skin. If it can breach the surface of the skin in any way, if it can go into a hair follicle, for example, it can cause a little localized infection in the hair follicle. It sometimes causes quite a strong inflammatory response around the hair follicle. So you notice hair follicles kind of isolated with little inflammation around them, and maybe a little bit of pus showing in the hair follicle itself, and that is referred to as folliculitis. And this folliculitis is very easily spread. If you have a patch of folliculitis, you scratch and rub, you're spreading those Staph aureus around, and you're liable to spread them from one follicle to another. So often folliculitis appears as a rash of these infections, not particularly serious, and very easily dealt with, usually with a topical antibiotic. A stye is a folliculitis of an eyelash, and it's often extremely painful. It's a big nuisance because it causes your whole eyelid to swell. Of course, this is something which probably many of us are familiar with, especially from childhood. If you only have one or two styes every now and again, that's not a major problem. They're usually self-limiting and disappear. If you are continually having styes, then a patient is well advised to have a culture done of bacteria from their nose, because it might, or from high up in the nasal passages, because sometimes people set up a resident population of Staphylococcus in the sinuses, which acts as a continual source of infection to the eyes. These situations, like the staph that sets up folliculitis, the staph that sets up the stye, these sometimes are specific strains of the bacterium, which have some specialized virulent factor that allows them to do these things. Now, a furuncle is a fancy name for a boil, which many of us have had. And a boil is a localized infection it's an abscess. It has a specific structure. I'm not going to go into all the detail, but it has a very specific structure, which results from the immune inflammatory responses around the site of infection. And the abscess arises because the immune system is trying to isolate the source of infection. And it actually causes the formation of an area of inflammation around the site of the infection, which is quite large. And in the center, there's usually develops an area of pus, which is largely composed of dead white blood cells, which are attempting to eliminate the bacterial infection. And an abscess usually has a head, develops a head, an area of necrosis. And that necrosis opens up and the abscess empties through that opening. So a boil is typically only has that one head. And in fact, if the infection begins to spread out away from that contained abscess, you can end up with a wider spread infection, which is like an abscess with several heads. There'll be several areas of infection, several of these necrotic spots. That is called a carbuncle. Both of these, both boil and carbuncles, are intensely painful and relatively large. So they have the potential to produce septicemia, but in fact, the immune responses that are producing the abscess and the carbuncle are extremely strong and very well regulated. And usually these things are self-limiting. If not, if there are any signs of septicemia, then it urgently needs to be treated. Much more common is a condition, especially in children, is a staphylococcal infection called impetigo. And impetigo is a skin infection which produces small sores which are dispersed across the surface of the skin. And impetigo very often is spread in children by them scratching. It's itchy, or they feel, and then they move somewhere else, and they spread the infection widely, often across the face. So this is the typical impetigo. It could be mistaken for cold sores, but a swab of a culture from this will very rapidly show this is actually a staphylococcus infection. And you can see how it's being spread around the mouth here. It depends upon the strain of staphylococcus which is infecting the skin, because they actually produce a range of toxins. Those which produce these effects here produced in general by a substance called toxin A. And it's associated with these localized spots of impetigo. This is called non-bullous impetigo. But there is another toxin, of actually rather severe toxin, called toxin B, which is released from a site of infection like this, but which spreads generally and has its effects remote. It's an exotoxin. It has its effects remote from the site of infection. And it causes the skin to peel off like this. It can actually peel off quite a deep layer of the skin. And this is called bullous impetigo. And if widespread, is referred to as scalded skin syndrome, because it looks just as if the skin has been burnt and is blistering off. And is a potentially rather serious situation, because this can expose deep layers of the skin, and it's rather as if the skin is being burned, and certainly makes this liable for secondary infection with other bacteria. So this is a true scalded skin syndrome. You can see this deep peeling, and this here, this is occurring remote from the sites of infection, which are probably here around the mouth. This exfoliation has been caused by circulation of this toxin B. You can also have streptococcal skin infections. Here's a streptococcus in chains. We've heard a lot about streptococcus before in association with other diseases. But if you think back, you'll remember that there are many different strains of streptococcus, and they produce some very serious toxins, exotoxins, or they have the potential to. It depends on the strain. One of the exotoxins that they produce is an exoenzyme, a set of exoenzymes, which are hemolysins. And this gives one group of the streptococci their particular characteristic, which is that they're able to hemolyze red blood cells. And they produce this beta hemolysis. There's beta hemolysis there. Clearing of the red blood corpuscles, this on blood agar. And this is one of the groups that we are particularly, carry particular pathogenic capabilities. Most of the disease-causing streptococci, not all of them, but most of them, are actually beta hemolytic. And so these group A streptococci, Streptococcus Pyogenes, their Streptococcus Pyogenes sounds like it's one species. It's actually a whole group of different strains of these streptococci. And they produce a whole range of different substances which act as virulence factors, which allow them to become pathogenic. Streptolysins I've mentioned already. The next one we've already heard about, and those are the M proteins. And I think there's a picture here. These are streptococci here, and here they're capsules there. And embedded in these capsules would be these M proteins. And they are part of the system that allows the bacteria to adhere. These other things, just take a note that there are other exoenzymes. And these will have an effect on the host, but may also excite immune response from the host immune system. So here are the commonest streptococcal skin infections. The first is called erysipelas, and it causes a widespread tissue destruction and a peeling of the skin, and may also produce sepsis, gram-positive sepsis. The one that there are two other diseases that you've probably heard about. The first is necrotizing fasciitis. This is also called flesh-eating disease. And sorry, this is erysipelas here. Erysipelas can be widespread across the body. It can be a chronic condition, and certainly in ancient times, it was one of the biblical dreaded skin diseases. So which was often confused with leprosy. So this erysipelas caused by Streptococcus. This is a terrible picture of necrotizing fasciitis, and this is due to specifically here due to a Streptococcus. Now, this flesh-eating syndrome can be caused by many different bacteria, but their characteristic is that they are able to produce massive amounts of exotoxins and enzymes, which result in massive loss, especially of connective tissues in the tissues, and tissues just tend to lose their integrity and almost fall apart because all the connective tissues especially are being lost. And that is largely due to these kinds, hyaluronidase and streptokinases. A hyaluronidase, just that is this is attaching hyaluronic acid, which is a component of the connective tissues. And it's these kinds of exoenzymes which enable the bacteria to very, very, very rapidly cause this kind of massive tissue damage. Extremely dangerous and very difficult situation to deal with. Okay, is there anything else I need? Oh, yes, I just want to mention this. We have talked about this before, but I will just remind you of this. And that is that both Streptococcus and Staphylococcus can produce a toxic shock syndrome. That is, if they set up a site of infection and you have the correct strain that produces the exotoxin, they can release exotoxins which go into circulation and cause the equivalent of a septic shock. The most famous instance of this was where a new tampon was developed, I believe in the 1980s. This tampon allowed women to keep the tampon in the vagina for a long period of time during menstruation, instead of having to change the tampon frequently. Unfortunately, a batch of these tampons became infected with a staphylococcus. Now, the staphylococcus, in the presence of menstrual blood and everything which the tampon was absorbing, which is what it's supposed to do, the staphylococcus bred in the tampon. The staphylococcus did not spread out and establish a septicemia, but the staphylococci in the tampon released exotoxins, which then got absorbed and caused an epidemic of this shock syndrome. Numerous women succumbed to the shock as a result of this terrible incident. So that is a typical example of a shock, of a toxic shock situation, of a site of infection, but the exotoxins in circulation are what cause the actual disease response. Okay, so let's talk a little bit about the commonest of the skin disease. And this is acne. I think everybody, all of us have had acne to one degree or another, because it's the most common skin disease in humans. And under normal circumstances, this is what a normal hair follicle looks like. Acne is actually a disease of the hair follicles. And under normal circumstances, here's the hair growing here. The hair moves smoothly through the hair follicle and grows continuously. And part of that is because each hair follicle has associated with a little sebaceous gland which produces lipids. The lipids that it produces have a specific name, and that is sebum. Sebum is actually the result of activity of these sebaceous glands. And under normal circumstances, sebum is there to lubricate here, and it also is supposed to have some protective activity because it's supposed to kind of seal the top of the hair follicle. But it's very easy, especially if sebum is overproduced, for it to actually block the hair follicle. Now, the problem is that, of course, this whole area here is liable for colonization, especially by staph and things like that, by bacteria. But as long as the hair is growing smoothly like this and sebum is continuously produced, there's no problem. You're continually moving bacteria out. But if this becomes plugged at all, then the bacteria can begin to grow around the hair follicle. And this sets up an inflammatory situation. And we end up with a small, it's like a small abscess. We end up with this area of inflammation and a plug, and sometimes here, a small area of pus. And there's your pimple. That's exactly what the pimple is. Now, there's different degrees to which this happens. Normal acne, with the kind of acne that most teenagers suffer from, and adults can suffer from all through their lives, in actual fact, and all of us periodically may have patches of, is called comedonal or mild acne. And it's just from the blockage of follicles. And if it's just pus, then it appears as a whitehead. If the sebum actually remains there and oxidizes over time, it will form a blackhead. It is a myth that blackheads are due to accumulation of dirt. They are not. It's the result of oxidation of the sebum that causes them to darken and look black. And this kind of acne is relatively easily treated with good hygiene and using topical kind of applications. However, acne, because this is an inflammatory situation here, this inflammatory situation can progress and become rather more severe. And this is the kind of acne that torments teenagers. And it's the result actually of an infection by another bacterium called Propionibacterium acnes. That's the commonest cause. And it actually feeds on the sebum. The other bacteria have tended just to get trapped inside and set up an inflammatory situation. But this Propionibacterium, actually, the population increases in the presence of sebum. And they release fatty acids, which excite an even stronger inflammatory response. So this is inflammatory or moderate acne. And these are the larger pimples with a wider spread inflammation. This is the sort of thing that torments teenagers and stops them from going to the prom. Some people, it is not known why, but some people, their acne progresses to what is called nodular or severe cystic acne. And this is a production of far deeper inflamed lesions with abundance of pus deep inside the skin. It's almost like abscesses developing in the skin. It is a much deeper lying inflammatory response than either of these. And this is severe cystic acne, and you can see how some of them are forming these large cysts as a result of inflammation deep in the skin. And it is this kind of acne which frequently results in scarring as time progresses. And I just want to say a couple of things about acne. The first is there is no association with dirt. There is no, you do not get acne because you have a dirty skin. You get acne because of a fault in the production of sebum from the hair follicle and of its functions. And that is the only cause. And then infection with bacteria. The nature of sebum changes in response to hormonal influences. So, for example, that is one of the reasons why teenagers are far more susceptible. They produce, for some reason, more sebum, and the sebum has a tendency to clot in the hair follicle. This may also happen with women who, as they undergo menstruation, different stages of menstruation, women may notice that they are more likely to have acne. So it's just largely response to hormonal changes that acne occurs, not because the skin is dirty or anything like that. And in actual fact, religiously scrubbing the skin in order to try and deal with acne is probably one of the worst things that you can do, because you encourage all of the inflammatory responses. And what you're observing in acne is an inflammatory response. And you can actually make that worse by brutalizing your skin, trying to keep it clean. Acne has nothing to do with dirt. Okay, so just a few more. First of all, just because they are so common, I thought I would tell you a little bit about not fungal, not bacterial, but some other organisms, and in this case, the fungi. So any fungal infection we refer to as a mycosis. And these cutaneous mycoses, fungal infections of the skin, are incredibly common. We can have fungal infections of the hair, nails, of the outer skin, and almost all of them, what is happening is they are metabolizing keratin, the principal tough protein that makes up the horny cells of the outer skin and of the nails and of the hair. And they actually are able to break this down. They release exoenzymes which break this down. Very often, these fungi are actually growing underneath the layer of keratin on the skin or in the nails. And they migrate through by breaking down keratin and putting out hyphae, little fibers, which spread the fungal colony underneath the skin. That at the same time can excite an immune response, especially in tender areas, thin areas of the skin. And this produces the effects that we observe. These skin impacts are referred to as dermatomycoses, fungal infections of the skin, dermatomycoses. And they are often referred to by common names, but in fact, you should not assume that these are different species of fungus. They may be, but we name them really by their site, the place where they occur. And they are often referred to as tinnias or ringworms or things like that. So, for example, a Tinea Capitus, this is a dermatomycosis of the skull. And it's especially common in children, and it can produce an area of baldness where the hair just falls out and fails to grow. Very easily treated and usually self-limiting. Tinea cruris, this is infection, a fungal infection, usually of the crotch and of the genitals. And it produces an intensely painful, a scalding kind of inflammation. This is especially associated, especially common during summer and in during humid weather for some reason. So this is Tinea cruris or jock itch. It can occur in both men and women, by the way. It's not isolated to men. Tinea Pedis, this is athlete's foot, and it's a generalized infection of the foot, but it is especially noticeable between the toes because it causes cracking of the webbing between the toes, which can be intensely painful. Complete myth that attaches to Tinea Pedis is that you catch it in the gym showers or whatever. In fact, most of us, almost every single human being, already has a population of the fungus on there and its conditions of the feet, which lead to it blooming and causing problems. And then Tinea unguium, I don't know how to pronounce that, is an infection of the nails. It can be of the fingernails, but much more commonly of the toenails. And it's an infection actually that's from the bed of the nail, which spreads through the nail itself and causes a yellowing and a brittling of thickening and brittling of the nails itself. So these are very many different habitats that these things can inhabit. This is ringworm, typical for it in a child, but adults can certainly get it as well. And as I say, it's usually self-limiting, but it's easily treated with a topical antifungal. Here's an athlete's foot. This is Tinea Pedis. What has happened here is that the fungus has completely weakened the upper layers of the keratin-rich, thicker skin, and this has led to cracking here between the toes. The treatment for these is usually with local antibiotic treatment, and you can easily buy these over the counter, and most of them are extremely effective. If the inflammation is particularly severe, then you might want to see a doctor and have an anti-inflammatory added to the treatment for the fungus itself. It's hard to say what the species is that actually causes the infection. There are several different types of fungus which can produce identical symptoms. So it's very difficult in these diseases to say exactly what you're dealing with, but fortunately, almost all of them respond very rapidly to the use of an antifungal. Okay, so I have talked about this before, but I thought I'd just show you this. Now, this is also a fungus, but this is a single-celled fungus. This is Candida, and single-celled funguses are referred to as yeasts. And these are the individual cells here, but they can form these filaments which join groups together. And this is typical. This here is typical oral candidiasis or thrush. A similar kind of infection can occur in the vagina, and is often also referred to as thrush or yeast. And in the vagina, it's usually in response to some change in the environment in the vagina, which has altered the pH of the vagina. Such a widespread thrush in anybody, in the mouth, for example, might be a sign that there is something else going on, particularly with the immune system. This kind of widespread candidiasis is typical for people who are immune impaired. It can occur in people with a normal immune system as well, but it is extremely unusual. However, in immunocompromised, this is extremely common. A couple of diseases of the eye, but most of these I'm going to simply refer back to things that we have already talked about. Inflammation of the eye membranes is again quite common and has many different causes, can have many different causes. Some of them not infectious at all. Inflammation of the conjunctiva, the coverings of the eye, can result very frequently from allergic responses and that sort of thing. But those in themselves can set up a situation where the eye is liable to infection with secondary infectious agents. So we commonly refer to this inflammation as pink eye, red eye or pink eye. The commonest bacterial cause of pink eye is Hemophilus Influenzae, which is this gram-negative bacterium, which actually is part of the normal microflora for many people. It has, the name is a misnomer. I've told you this before. Hemophilus influenzae, it has nothing to do with influenza at all. The name was given in error, and it's kept it ever since. Hemophilus influenzae is the most common bacterial cause of pink eye, but there are several other bacteria as well. It can also commonly be caused by adenoviruses or even herpes viruses. Now, the reason that I want to mention this is because if you have pink eye and conjunctivitis, then it's really important that it be properly diagnosed. Because if it is simply a bacterial infection like this, then it is usually easily treated with antibiotics. It's very important to distinguish these from a viral conjunctivitis. And it is especially important. There is a temptation to think that because you're dealing with an inflammatory situation, that anti-inflammatories might be useful. Under no circumstances should those anti-inflammatories be used if it is a viral infection, because it will make it far, far worse. They actually increase the ability of viruses to infect the cells of the eye. So usually these conjunctivitis are self-limiting, and people do not, they just, you wash the eyes regularly or whatever, and they can manage perfectly well. You can certainly use over-the-counter things to deal with, but under no circumstances ever should steroids be used in the eye unless it's under medical supervision. Now, the other thing that I wanted to tell you about was all of those of you who use contact lenses. It's extremely important that you observe very, very, very good hygiene with your contact lenses. Contact lenses provide an ideal surface for the development of microfilms, biofilms by various bacteria, amongst them the Pseudomonads and various other things as well. But the Pseudomonads are particularly important because they produce a strong immune response from the eye. Remember, go back and have a look at some of the other bacterial diseases of the eye that we have already mentioned: trachoma, herpes keratitis, and gonococcal keratitis. Go back and have a look and see that we mentioned those before. The last one, this is again just an admonition to those of you who use contact lenses. This is actually a strange organism. It's actually an amoeba called acanthamoeba. And acanthamoeba is a common component just of the soil and of water, so it's around. And this is a cause of can be a cause of severe eye damage in people who use contact lenses. If they acquire acanthamoeba in the contact lens and allow it to grow, they can get an acanthamoeba infection of the eye, which causes damage and clouding of the cornea. And it's so severe, although it can be treated if it's spotted early on, that it might even require a corneal transplant if the damage is severe. I just mention it because this is one of the few eukaryotes that we have talked about apart from the fungi. Okay, so let's just take a little break and then just finish off this last portion here. Okay, back again. So this is a very short section. I just wanted to talk to you a little bit about some of the diseases of the nervous system that we have not mentioned already. Remember that we have discussed meningitis and those disorders already. So go back and have a look those again. But I did want to talk about, first of all, this group of bacteria, this genus called the Clostridia, because there are at least two of them that produce such profound disorders of the nervous system that we really should pay some attention to them. The first one is this one, is Clostridium Tetani, and unsurprisingly, it causes the disease tetanus. So this is what it looks like. These are gram-positive rods. By the way, this is not a gram stain here. It's another stain. So, but you can see, just have a look at this one here. And you can see there's the cell there. That's the vegetative cell. At the end of the cell there, like a tennis racket, that blue stain there is staining a spore. So these are gram-positive spore-forming bacteria. That spore is tremendously important because the Clostridia in general will only grow under strict anaerobic conditions. They cannot tolerate the presence of free oxygen. The emphasis on free oxygen, as I'll point out in a second. So these spores are very small, they spread very widely, and they last a tremendously long time. Hundreds, if not thousands of years, they will survive without any apparent metabolism or anything like that, just waiting for the opportunity to find the right conditions under which to grow. So Clostridium Tetani is a common component of soil. And if it gains entry to a wound, the wound, in fact, is an ideal environment. Now, you might think, well, why we've surely got oxygen circulating around our body the whole time. Our body tissues require oxygen the whole time. So how is it that a wound can be anaerobic? The point is that, in fact, it is presence of free oxygen they cannot tolerate. And our oxygen in our body is transported bound to hemoglobin and then directly to the cells and given directly to the cells. We don't have free oxygen circulating in our bodies. Our oxygen is bound to hemoglobin. So our tissues can, in fact, present an anaerobic environment to bacteria such as Clostridium. The commonest way for a wound to become infected with Clostridium is through things like soil. In other circumstances as well, manure, for example, cattle manure is supposed to be a particularly favorable environment for the bacterial spores. So if we get a wound which is contaminated, then we are liable for a Clostridium Tetani infection. And you only need a very small population of Clostridium to grow because they release this exotoxin, which is extremely powerful. It is extremely powerful in very, very low doses. So you don't need much of a population to produce a catastrophic effect. And this is, Clostridium releases a neurotoxin, which blocks the ability of muscles to relax. It causes the muscles to go into spasm. And these become so profound that, in fact, people can die from fracturing their own vertebrae. They break their own bones. The muscle cramps and contractions are so powerful. And they eventually often will die of respiratory failure because they're unable to respire. All of the muscles, including the diaphragm, contract and will not relax. And so they just can't breathe and they die. There's this classic illustration of a soldier, I believe in the Napoleonic Wars, suffering from tetanus. And this is a typical contracture of all of the muscles into this permanent spasm. So tetanus causes it's paralytic, but it's paralytic by contraction. It's affecting the abilities of the muscles to normal muscle movement. Now, what's really important to note, this is not being produced by a septicemia. It's not even being produced by a very large population of bacteria. But if you can just eliminate the impact of this toxin, the body itself is very quickly able to eliminate the infection. If you deprive the bacterium of this virulence factor, which is this exotoxin, which has all sorts of other benefits for the bacterium, apart from the fact that it causes death in the host. If you eliminate that toxin, the bacterium is not able to flourish. So our treatment for tetanus is to administer a tetanus antitoxin. And the antitoxin is actually what we're doing is we're training the immune system to recognize the presence of the toxin. And it's our own antibodies which eliminate it. You can administer, in the case of somebody who actually is suffering from tetanus, you can administer antibodies from another source against the toxin. But under normal circumstances, if we are wounded, like you stab your foot in the garden, and you haven't had a tetanus vaccination for a while, you go have a tetanus vaccination, and your body very quickly produces antibody to the toxin, eliminates the toxin. And if you eliminate the toxin, then the bacterium is unable to flourish. You don't need to be treated with antibiotics for the bacterium itself if you take away its principal weapon, which is its exotoxin. So that's the one Clostridium. The other Clostridium of interest is Clostridium Botulinum. And this is the cause of botulism, which is actually a food poisoning. Again, it's a gram-positive endospore forming obligate anaerobe, just like Clostridium Tetani. But it grows under conditions of absolute anaerobiosis, and it also requires a neutral environment. It doesn't grow in acid, in an acid environment. And it really, again, releases an exotoxin. And the exotoxin can actually accumulate in the medium in which it is growing. So if you were to eat something in which Clostridium botulinum had been growing, you would eat as well the exotoxin that is produced. And this is an extremely powerful toxin, exotoxin, which is specific for nerve endings. And it is a competitive inhibitor, so it binds permanently to the nerve endings, to molecules at the nerve endings. And it blocks the release of acetylcholine. It blocks the release of the neurotransmitter, which causes muscles to contract. So the muscles lose their ability, completely lose their ability to contract. So this is now another kind of paralysis. This is a flaccid paralysis, where the muscles just cannot contract at all, and they go completely limp, all of the muscles. And death as it results from respiratory failure or from cardiac failure. And so let's just think about this for a minute. This has to grow under absolute anaerobic conditions. And it has to grow in a neutral environment. What is an ideal environment? Remembering that its spores are resistant to boiling. Well, the ideal situation is in food canning, in food preparation. Because if you can something like beans, they are practically neutral. You're creating an environment which is completely free of air, of oxygen. That's the whole idea of canning. You boil it and then put a lid on it and let it cool. It doesn't have any air in it, so it slows the growth of bacteria. It stops the growth of most bacteria, but it would not stop the growth of Clostridium. And Clostridium grows in a can, releases exotoxin. You then open the can and prepare a bean salad, whatever, and eat the toxin, and you get the flaccid paralysis. This used to be a common cause of death from food poisoning. Nowadays, it is very uncommon because food preparation practices have improved so much. In addition, you can, even if you're suffering from it, you can be treated with antitoxins, antibodies against the toxin from another source, and also with respiratory assistance, and until you actually recover. But you have to be treated, because it's a competitive inhibitor for molecules on the nerve endings. You have to be treated until those nerve endings actually regenerate, which may take a long time. Food practices are now specifically designed to track the possibility of contamination by Clostridium. So it's very, very rare, and is mostly nowadays isolated to people who do home canning when it does occur. There is one instance, however, where it can occur, and this is in children, in infants. And in young infants who do not yet have a mature microflora in their guts, and their microbiota is not yet mature. If you feed them Clostridium spores, those spores can germinate in their guts and produce a flaccid paralysis. So this is one of the reasons why you should never feed an infant honey. For some reason or another, honey is a particularly rich source of these Clostridium spores. And so young children, infants should not be given honey. I think I have I don't. I had this used to be, botulism used to be a major source of mortalities, particularly as canning became established and was done widely in homes to preserve food. And I didn't include it here, but I have a spectacular picture of a family of 9 people, all the coffins laid out at a funeral from one single family who were all decimated by botulism. The only other thing to mention about botulism, of course, is that we make use of the toxin, and that is Botox. That is what Botox is. Botox is a muscle paralyzing injection, and it's used cosmetically to relieve wrinkles and things like that. But it is used medically as well. For instance, there are several conditions where there are muscle contractures, which are damaging, and those can be relieved by injections with the Botox, which cause the muscles to be able to relax. I would also mention that apart from Clostridium Tetani, these 2 Clostridia, both Clostridium perfringens and Clostridium botulinum, can also grow in wounds. They can infect wounds. Clostridium botulinum wound infection will produce the same effect, a paralytic flaccid paralysis. Clostridium perfringens produces a gangrene, and this is often referred to as gas gangrene. One of the characteristics of all of the Clostridia is that they're obligate anaerobes, and they ferment substances, and they often produce gases. Clostridium perfringens produces abundant gas, and this can actually produce a gangrene, which is inflated by the gases contained within it. Okay, so I believe this is our last one. And I just wanted to mention it because we have mentioned before its sister bacterium. This is, and the disease we're going to talk about now is leprosy, and it's caused by Mycobacterium leprae. The other Mycobacterium that we talked about was Mycobacterium tuberculosis, which caused tuberculosis. Mycobacterium leprae looks rather similar. It's again an acid-fast bacterium. Here it is in tissue here. And here you can see the bacteria. They are red on acid-fast staining, which is diagnostic of a mycobacterium. It's an acid-fast rod that actually has rather specific temperature requirements. It grows best at 30 degrees Celsius. This means when it infects human being, it tends to grow best on the peripheries. It grows best in the nose, ears, fingers, toes, those kind of areas where the temperature is somewhat lower than the 37 degrees that pertains in the core of the body. It has a very slow growing bacterium, just as Mycobacterium tuberculosis was. Unlike Mycobacterium tuberculosis, it grows in peripheral nerves and in skin cells, but it is through its occupation of the nerve cells that it exerts its greatest effect. One of the characteristics, just as Mycobacterium tuberculosis did, it survives the ingestion by macrophages and breeds inside macrophages. But it actually also infects macrophages, which specifically associate with nerve cells. And it begins to invade and destroy the myelin sheath of nerve cells. And is that destruction of the nerve cells or the myelin sheath which produce some of the greatest effects of leprosy. One of the first impacts is that people begin to develop a numbness in the fingertips and peripheral areas. And then there is progressive loss of tissue from those areas. Very often that is exacerbated by the fact that they continually damage the areas where they have lost sensation. And it ends up producing massive deformations of the limbs, of nose, face, etc., etc. And it's then actually, once that has advanced, it begins to spread, and it spreads through mucous membranes. For a long time, there is this battle between the immune system and the mycobacterium, which kind of keeps it in check, somewhat similar to Mycobacterium tuberculosis, which maintained it in those tubercles. Eventually, it can break out and become disseminated and then end up being fatal. It begins to infect the nervous system and the heart as well. It used to be far more common than it is in modern times, but it certainly does occur, and it occurs really widespread. It is diagnosed rarely but regularly in the United States, about 100 cases a year. But as with Mycobacterium tuberculosis, it is treatable with now treatable with antibiotics, but it has to be treated over a very, very long period of time. But it has a very low infectivity rate. So very soon after antibiotic treatment begins, people are completely non-infectious. So it's nowadays not as great a problem as it used to be. These are typical leprosy lesions. This is a skin lesion where it's infecting the skin cells and producing this patch. This here, these are fingers that have been infected and tissue has gradually been lost. What has happened is that first of all, the nerve cells have been impacted, sensation has been lost, and skin cells have also been infected, and continual damage leads to progressive tissue loss. It's almost as if the fingers just recede and are lost. And I think that is it. So I will be in contact with you to discuss a review session But apart from that, I've enjoyed teaching you, despite the fact that it has been online. I hope that you have learned a lot, and I wish you all the best.